All right, and I am excited to introduce Dr. Rebecca Lundquist, that I have had the pleasure of working with in several areas and aspects, and this is one of them. Dr. Lundquist is a program director of the Broadlawns Community Point Health Psychiatry Residency in Des Moines, Iowa. She is an adjunct professor of psychiatry at the University of Iowa Carver College of Medicine and affiliate professor of behavioral medicine at Des Moines University College of Osteopathic Medicine. She is the president-elect of the Iowa Psychiatric Physician Society and a board member of the Iowa Medical Society Foundation. And she's also served as director of the Outpatient Psychiatry Clinic and the Women's Mental Health Clinic at UMass Memorial Medical Center for University of Massachusetts Medical School. Her clinical interests include perinatal psychiatry and psychodynamic psychotherapy. She's a graduate of the Wright State University School of Medicine in Dayton, Ohio, and completed her residency at the Harvard Long Psychiatry Residency Training Program in Boston, Massachusetts. That is my spiel for the beginning. Dr. Lundquist, please feel free to take it away.
All right, so thank you, Christina. I apologize for the audio difficulties we've had during this. If you cannot hear me, please throw up a hand and we will work to try to improve any technical difficulties we're having. So I have no disclosures of financial relationships that are relevant to this presentation. The learning objectives I share with Dr. Kopelman, who spoke last month, and I hope many of you were able to talk to her about screening and referral. We're going to touch on a lot of those same themes today, but today we're going to focus on formulating an initial treatment plan for uncomplicated depressive and anxiety disorders, as well as my take on some of what Dr. Kopelman talked about. So, why is this important? I think each of you has decided it's important, or you wouldn't have chosen to come here today and spend your lunch with us. But the consequences of untreated mental health and substance use disorders in perinatal people and people in general are, of course, enormous. There's a dire shortage of those of us who specialize in mental health and substance use disorders, and even a more dire shortage of perinatal subspecialists nationwide and in Iowa. But that doesn't mean, I firmly believe that, that doesn't mean we cannot help people. This is what I've spent my career telling people, is that everyone can help, and that it's a shared responsibility across everyone in the healthcare sector who touches perinatal patients. And I hope I will empower you to believe that you can be a part of the solution. So we know that Iowans believe that this is important. There was a maternal health strategic plan formulated by the Iowa Department of Public Health in 2021. Mental health popped up over and over and over again, to the extent that a very specialized maternal mental health strategic plan was released in 2023. And if you want to read it, there's a link on this slide. So what can happen if we don't treat mental health and substance use concerns? And just to let you know, I'm not going to specifically talk about substance use disorders today. You're going to get the chance to hear from Dr. Lynch later in this series. But I certainly can, if people have burning questions today, I certainly can try to answer questions. But mortality can happen. Other poor outcomes for both mom and baby and families, lost economic opportunity, lost ability to parent to one's full capacity. And the ray gun tea towel is a testament to that. So how do babies do when there's perinatal depression? You can have preterm birth, increased risk, low birth weight, longer-term temperament and behavioral problems, negative effects on bonding and attachment, difficulty in having success breastfeeding, cognitive and social development can be affected, and then risk of future psychopathology. We think mostly because of difficulties in parenting that can happen in these situations. And I say this, I want to be really clear. I say this not to shame mothers into accepting treatment, but to help us taking care of perinatal patients to be able to make the case to ourselves, to the places where we work, and to patients about why we should take this seriously. But I do want to acknowledge that there's a very fine line between shame and offering assistance to folks. And this population of patients is especially vulnerable to feeling shame. We shame moms for just about everything in our society, and depression and anxiety are no exception. So the economic costs are huge. In 2017, some economists did an estimate that $14.2 billion is lost in the US annually. And with our share of the births, we can estimate that at about $15 million annually in Iowa. Since we have 1% of the nation's birth, this is lost productivity. This is the cost of treating patients who went untreated and had their illness get more severe, and a number of other factors that I don't completely understand because I'm not an economist. Maternal mortality, mental health and substance use disorder has overtaken pretty much every other cause of mortality to be the leading cause of maternal mortality in the nation and also in Iowa. Note that the two slides I just showed you are for two slightly different time periods. The Iowa slide has post-COVID data mixed into it, and for that reason has COVID, but COVID was the second leading cause of death in that time period, and suicide and substance use disorders was the leading cause of death. So this is a serious problem here in our state, and maternal mortality is the very painful tip of that iceberg. So what do we do? I resonate with this very deeply as a mother of a now 18-year-old, but every minute as a parent, I wonder this. So we know that there's a mental health professional shortage area. We know it's shortage. We know there's a dire shortage of health professionals in general. The navy blue on this slide, and this is every county in the United States. The navy blue on this slide is the whole county is in a shortage area. And I'm going to show you Iowa next, so you don't need to squint. This is Iowa. Where I'm sitting in Polk County, we've got none of the county in a shortage area. And I'll tell you, I'm looking at Dr. Perry, who runs the clinic here at Broadlawns. We have trouble getting help for our patients, even though we're light blue. And so I feel you if you're in a dark blue or a medium blue county. And we want to find a way to be helpful to you. So what do? I resonate with this slide too. I always try to help. Sometimes I have no idea what's going on. But we're going to try to help you figure out so that you don't feel like you have no clue. But yes, I feel that dog very deeply. So these are 3 resources, and as we dive into the resources, you'll see why I chose them. All of these have extensive websites that you can take a deeper dive into in future lunch hours. So that you can learn what each resource has. I encourage you to do that and to spend some time doing that if these are unfamiliar resources. And even if they are, I think resources get added and changed. So first deep dive is McPap for Moms. This is a program that's near and dear to my heart because I was involved at the very beginning about 10 years ago. McPap for Moms is a Massachusetts resource, and even though I'm going to encourage you to download the toolkit, I would like everyone, in fact, to pledge to download the toolkit. You will find phone numbers all over the toolkit and all over their website. Those phone numbers are for Massachusetts providers only. I will give you some different phone numbers that you can use. The clinical information in there is good. Because Massachusetts thankfully does not have a big problem with methamphetamine, you will find very few methamphetamine resources, but never fear. Dr. Lynch will be here in, I think, September, October to help you with that. But there is excellent resources on both mental health and substance use disorder, algorithms, all kinds of things that I'm going to walk you through the toolkit as my way of helping you figure out how to talk to perinatal patients about positive screens, how to initiate and sustain treatment, and how to know when you need to reach out to a specialist. This is the table of contents for the toolkit. As you can see, it's got a depression screening algorithm. It's got the Edinburgh if you need that. It's got how do you assess depression severity once you've done a screen? How do you know if the person might have bipolar disorder and you don't want to give them an antidepressant? A summary of all the different kinds of emotional complications you can have during the perinatal period. Some key clinical considerations, and then recommended steps. And an antidepressant treatment algorithm. We're going to take a deeper dive into those. It also has significant resources for helping with substance use disorders. It is the standard of care to screen perinatal patients for both anxiety and depression and for substance use disorders, and you can get those tools also in this toolkit. Okay, so this one is about screening. How do you screen? When do you screen? What do you do with a positive screen? I am fully aware that this is probably too small for you to read in depth, but take a look at it before you, if you have never screened, or even if you've been screening, take a look at it in order to see what the standard of care for screening is. And Dr. Kopelman may not have said this, but I am personally agnostic about what screen you use. You can use the Edinburgh, you can use the PHQ-9. I don't think using the PHQ-2 is all that useful. I encourage you in this population to use the PHQ-9. You can use the GAD-7 to screen for anxiety if that's what your organization likes to use. The Edinburgh is specific to perinatal patients, but it's also been validated in all kinds of populations of people who are not pregnant. So I have become pretty much completely agnostic about what screen you use. Just use a screen. Really important. How do you assess? This one's got all of the Edinburgh scores on it. The primary care toolkit, if you download that instead of the obstetric toolkit, has all of these with the PHQ numbers on it, which could be really useful. This one is a summary of all the different kinds of emotional complications. If you need to have a review on that, you can have that handy on your desktop. This one is items to consider when reviewing a screen, and what it's got is how do you assess thoughts of harming the baby? That could be really scary if that comes up when you're talking to a patient. How do you decide whether to offer or not offer medication and help a patient decide about taking it? What are the risk factors if you need to review that? Other considerations you might include in a clinical assessment. So a past history of psychiatric diagnosis, really important. Previous history of psychotherapy. What have they taken for medication in the past? Support groups, substance use treatment, anxiety and worry, trauma history, domestic violence, all of those things can play into making a decision about what to recommend for a patient to do next. And then some, what I call icebreakers. If you're not sure how to talk about perinatal depression with a perinatal patient, there's some icebreaker questions at the bottom that can really help you start a relaxed back and forth conversation with your patient if this is an uncomfortable topic for you, or even if it isn't and you're just looking to be able to do better at having these convos. So, recommended steps. So you've decided that you would like to offer an antidepressant. What do? You want to counsel the patient about antidepressant use. One of the things I always say to the patient is no decision about whether to use antidepressants during pregnancy is risk-free or perfect. We do know a lot about the safety of antidepressants in pregnancy. The short version is that almost any antidepressant other than monoamine oxidase inhibitors, which very few patients are on, have been proven to be relatively safe in pregnancy. We know that untreated or undertreated depression during pregnancy has all kinds of risks that go with it. And so choosing not to take an antidepressant doesn't avoid all risk, it just avoids a set of risks. And for patients with severe illness, it very well may be the better choice. SSRIs are among the best studied classes of medications during pregnancy, and we'll get into the details in a minute. You should offer both medication and non-medication options to patients. Encourage psychotherapy if a patient has that available to them. We talk about small but inconsistent increased risk of birth defects when taken in the first trimester, particularly with paroxetine. I would say the more that we study these, and we've been now studying SSRIs in pregnancy in earnest and quite seriously for about 20 years, I can say pretty confidently that the SSRIs are not associated with an increased risk of birth defects, with the possible exception of paroxetine, which I don't recommend you prescribe anyway because it's got all kinds of other problems with it. Unless you have a patient who's already on it. And if somebody would like to ask me a question about that later, I'd be happy to answer it. The preponderance of the evidence doesn't suggest birth complications with SSRIs. Studies do not suggest long-term neurobehavioral effects on children. Those studies have now been done multiple times over decades. And there's possible transient neonatal symptoms. I think these were very overblown about 15 to 20 years ago, to the point that we had women stopping antidepressants in the third trimester and having both discontinuation symptoms as well as resurgence of their depression and anxiety symptoms. And that was not a good situation for many, many patients. So in general, if we've decided to be on a medication in pregnancy, if a patient has decided that, I don't recommend that they stop or decrease in the third trimester. So we talked about the risks of undertreatment or no treatment. So in a lot of situations, the benefits of taking an antidepressant can outweigh the chance of the things we just talked about. And in lactation, for most antidepressants, and especially the SSRIs, these are present at very, very low levels in breast milk, and all of the SSRIs are very compatible with breastfeeding. It's a lot of information. Again, that's why I'm recommending that you download the toolkit so that you can have this information and you can have the references for all of this information in case you want to take a deeper dive yourself. Okay, so this one's really small, but I will take you through it. So this is the antidepressant treatment algorithm. So I'm going to walk you through it. So the top of it is patient currently taking an antidepressant? If yes, you want to ask, are symptoms improving but not resolved? Or is the patient on a therapeutic on a therapeutic dose that hasn't helped? So if the symptoms are improving but not resolved, in most cases, you want to increase the dose of the current medication. I will tell you that what the science is showing us and what my patients are showing us is that in the second half of pregnancy, you often have to make several increases in the dose of the antidepressant medication because pregnancy causes a decrease in the level of the medication. So it's not surprising if you have to increase the dose to what may seem like a very large dose to you. So if the patient's been on a therapeutic dose for 4 to 8 weeks, and the table below tells you what the therapeutic range is, you can consider changing the medication. I will tell you that for several of these medications, I've had to go in the third trimester beyond the therapeutic range for several of these medications, and we'll talk about that in a second. Again, does the patient have a history of taking an antidepressant that has helped? So that's up at the top here, if you can see my arrow. So yes, you want to prescribe the same medication that has helped the patient in the past. If the medication appears on here, you've got some dosing recommendations. If it doesn't, you may have to look up the dose. But if it's not a monoamine oxidase inhibitor, I would say go ahead. There's much less data on some of the newer antidepressants. You can go to www.womensmentalhealth.org. That's the Mass General Women's Mental Health Clinic website. They will have information on some of the newer antidepressants and some of the ones that don't appear here. And if people want to remind me to type that in the chat, they can put it in the chat now for me to do that. I'll be happy to do that. Okay, so no, they haven't ever tried an antidepressant. First line for those patients is generally sertraline. That's what I tried. It's probably your favorite antidepressant as well if you've treated these folks. Generally start at 25 milligrams, titrated up to a therapeutic range of between 50 and 200 milligrams. I will say it's not unusual, and Dr. Oyugi can confirm when she talks that we get up to 250, sometimes even 300 milligrams a day in that late stage of pregnancy. If you've done that, you're probably going to have to decrease it after baby is born because you're going to get beyond the level where they're going to have side effects when they're no longer pregnant. This sheet talks about general side effects of the medications. It talks about repeating the Edinburgh or whatever screen you were using to evaluate whether or not there's a response to the antidepressant. The wonderful thing about these screens, the PHQ-9, the Edinburgh, is you can use it to look and monitor for treatment improvement. And if you're seeing it just stay flat, you need to either change the dose or switch to a different medication. And you want to be seeing those patients monthly if you're the one prescribing the medication. All right, so we're going to move on to Postpartum Support International. Iowa has a chapter that's very active. There are a ton of resources, but we're going to scratch the surface today. There's online support groups for patients. There's a provider directory that includes 68 providers in Iowa, both prescribers as well as therapists. Many of them are available through telemedicine. There is a helpline for patients to call or text. And I added the federal HRSA helpline as well. You can call or text that number, or your patient can. They have resources for training and consultation, perinatal mental health certification. If you enjoy learning about this and would like to learn more, you can take a deeper dive and take a course. Psychiatric consultation line through an online form. So this is your substitute for those Massachusetts phone numbers that are on the MCPAP for Moms toolkit. You want to go onto the website, hit the, I think it's for professionals is what it says on the website. I looked right before I got on here and now I don't remember. But you can press the button to get to an online form and request a consult with somebody who does this work, who will then make an appointment to talk about your patient with you. You will, if you are doing this, run into patients who are more complicated than what I've just explained, and that's okay. And you can certainly also refer those patients to be seen. I want to let you know we can see those patients at Broadlawns through virtual if your patient is in Iowa, and you can contact me. I'll put my email in the chat when we're done. If this really intrigues you, there's an annual Postpartum Support International conference that you can attend. It sells out every year, very, very popular. But there's a ton of resources on that website. All right, Your Life Iowa. Your Life Iowa has a phone line, and this one, the phone line and the text line are different, but you can go to the website. You can also live chat on the website. This is more for patients than for us. But there are a ton of resources on the website. Where are our substance use treatment facilities? How can you get an appointment with a mental health professional? All of those things are on the website, and the Iowa HHS works very hard to keep those things current. And accurate. So even though we are undergoing a ton of changes in how healthcare is done in this state right now, I'm pretty confident that the Your Life Iowa team is keeping up with those on the website. I hope they are anyway. All right, so we are ready for our case presentation.